Hi, everyone. I'm Dr. Rob McKenna, and I'm an advisor with the Health Resources and Services Administration. I'm super excited to be here with you. I'm super excited you're here, and it's my pleasure to introduce this session's speakers, and that would be Dr. James Powell, who is the Chief Executive Officer and the Chief Medical Officer of Long Island Select Healthcare, which is a federally qualified health center, and Terry Sepala. Oh, I hope I said that right, Terry.
Sepala.
Sepala, who's the CEO, president of Telehealth Associates, a telehealth consulting firm. So I want to remind everybody that you were showed this morning, if you had a chance to attend this morning's session, how to join live polls. This session does include polls, and so you can access them from the app itself, just at the little button under session engagement that says join live poll. And right under that, where it says ask a question, if you click on the arrow to the right of that, you can begin asking and inserting your questions, and remember you can vote them up. So we'll have mostly didactic presentation, and then we'll have about 10 minutes at the end where we can have some discussion and address those questions. So thanks everyone, and let's go ahead and get started.
Great, thanks so much. We'll take next slide, please. So we're so excited to be here and share what we're doing, and really welcome to the new normal. Just for me, just for disclosures, no financial disclosures to report. I'm not being paid to do this. In fact, I was almost offered money not to tell jokes about my kids, but contract negotiations broke down. So game is on. So we'll see how this works out. And I'll hand it over to Terry to start our end. So thanks, Terry.
Okay.
Next slide.
Hi, everybody. Thank you for inviting us to present. And I'm Terry Sepala. I'm the founder of Telehealth Associates. We are a New York City and New York State certified woman-owned business, and we specialize in helping clinics and providers incorporate telehealth into their practice. We've been operating in this space for 15 years. And our sweet spot is working with FQHCs and community health centers and vulnerable populations, which is how we came to know Dr. Powell at Long Island Select Healthcare. We invited Dr. Powell to be our supervising physician for a New York State Department of Health telehealth grant that we were building and managing. And now that the grant is over, we continue to work together with LISH is Long Island Select Healthcare, to make LISH's virtual clinic sustainable, to serve patients at home, in congregate settings, in schools. And that's what we're here to talk about today. We're here to share the journey of moving from having a grant-funded telehealth grant to sustainability. And I think we'll go to the next slide and just see who our audience is. Have you ever received a telehealth grant? You can choose 1 for yes and 2 for no. So 100% of you have either received a grant or are winding down on a grant, and that's wonderful. So you've come to the right place, because Dr. Powell and I have some tips for you. But first, let me mention that according to CMS Seema Verma, who was interviewed on June 9th, just a little while ago, said that she can't imagine going back. She can't imagine not having reimbursement for urban and rural Medicare beneficiaries, and that all telehealth codes during the pandemic should remain reimbursable. So hang on to your hats. I think telehealth is here to stay, and it's here for all. Next slide, please. The grant that I was just mentioning is a New York State Department of Health grant, And they awarded a 3-year, $6 million grant to a consortium of 60 agencies serving the intellectually and developmentally disabled population in the greater New York City area. And this consortium contracted with Telehealth Associates to build and manage an urgent care program using telehealth technology to bring the clinic into the home. We recruited over 2,000 patients from agencies and community. We vetted telehealth and remote patient monitoring technology. We hired medically led teams in Brooklyn and Long Island, and this is how we came to know and work with Dr. Powell at Lish. He became the physician supervisor for our grant. And as you can see from this slide, we had amazing clinical and financial results. We were all particularly proud that 98% of the patients and the caregivers wanted the program to continue. They loved that a telepresenter, in this picture, the nurse, would bring a telemedicine bag into the home to present the patient to a remote physician or to a nurse practitioner for a virtual diagnostic assessment. The grant was chosen by New York as one of 5 grants to receive an award of excellence in innovation and outcomes. And at the end of the grant, the Department of Health said, you have to find a way to make this sustainable with existing reimbursement because we don't have any more money to give you. So Dr. Powell was willing to rise to the challenge and work with Telehealth Associates to create a sustainable virtual clinic within Lish and model it on the grant's best practices. But we faced some mighty big challenges. The grant program's full telemedicine enabled care was too expensive. It was too labor intensive. It contained elements that were nice to have versus essential, and it simply could not be supported on pre-COVID FQHC telehealth reimbursement. Next slide. So as you can see on the left, the services that the grant provided were a triage call center, video visits, virtual diagnostic assessments with telepresenters, remote patient monitoring. There was no Medicare reimbursement to a non-rural FQHC for the grant components, and very little reimbursement from Medicaid. So that was discouraging, but Dr. Powell took the long view, and telehealth worked. He knew it, and he was determined that it would be part of Lish's future because it was inevitable. So together we had to rethink and rescale the program. We started by asking ourselves the following questions. Next slide. What did patients and caregivers find most valuable? Answer: patients seeing the doctor without leaving home. Another answer: caregivers feeling comfortable that the telehealth-enabled care team were an extension of them. What else could help fund a virtual clinic? Answer: FQHCs can be reimbursed for Medicare's Chronic Care Management Program, CCM, for individuals with 2 or more chronic diseases. And it turned out that 68% of Lish's census had Medicare fee-for-service as their primary insurance. And for those who don't know, the CCM program requires care coordinators to spend a minimum of 20 minutes per month per patient, non-face-to-face, to maintain an electronic care plan, manage transitions of care, and other care management services. And Lish did have medical assistants who could become the CCM coordinators under the direction of a primary care and behavioral health provider. Next slide. This is a poll. What is your relationship with chronic care management? Choose 1 for never heard of it until now. 2, plan to explore it in the next 12 months. 3, have a CCM program now. So 67% of you have a CCM program now, and 33% plan to explore it. I think you'll be interested in seeing how CCM can be a source of revenue as well as a financial and clinical anchor for a virtual clinic. Here's how. Dr. Powell, next slide.
Thanks, Tara. So we really realized that, to create the program, take a step back, my aha moment in virtual care goes probably back to about 2016, 17, when I diagnosed a nonverbal autistic young man with a high fever, listened to his lungs and picked up a pneumonia late one evening, made the diagnosis, had the antibiotic delivered within the hour, 12 hours earlier than I would ever seen him. So, I was so blown away by that experience that we said, how do we make this work? And so how do we kind of sacrifice perhaps dollars to create value for us down the road? So that's why I really decided to go with the chronic care management program for us. And actually prior to the COVID and going into 2020, with the help of our CFO, we actually budgeted about 4% of our visits would be virtual care and non-reimbursed in the FQHC world, because we realized, it's going to create value, it's going to help create outcomes, so we're going to prepare ourselves for that. We were kind of lucky in the sense that our CCM program could be so robust because we take care of a lot of individuals who have developmental disabilities, so autism, Down syndrome, et cetera. And what's interesting about with that is that when the parents become Medicare eligible, the children become Medicare eligible. So we have 30, 40-year-old adults that have Medicare. So it made it a little bit more robust. So we said, if we can make a robust CCM program, it'll offset the visits that will not be reimbursed for. And that allowed us to kind of create the model, saying, okay, well, how do we kind of scale this up? How do we look at the numbers? We had over 3,000 patients who are quote unquote eligible for virtual care. And so we knew if we enrolled about 1,000 people, we'd be able to get to those numbers. So prior to the pandemic, we were actually up to 1,300 visits a month. And today, as you'll see, we're at 2,000 visits a month for our CCM program. So it's really been a big piece of that for us. Next slide, please.
Yeah, so CCM gave LISH the opportunity for some financial assistance, but also a cohort of patients to pilot and practice telehealth. And so CCM, RPM, and telehealth visits are all essential to managing chronic care. They can add to the revenue, combined together, can add to the revenue for each patient and increase the number of quality touches per patient. So we saw how these three programs work together. We saw that from our grant that RPM could help CCM patients by monitoring their symptoms regularly before they worsen and intervening before they have to go to the ER or urgent care. Telehealth visits provide virtual check-ins by the clinician to encourage the patient to continue following their care plan or to intervene if the RPM readings show a worsening trend. CCM coordinators could participate by helping to troubleshoot technical problems. They monitored RPM compliance for patient readings, and they scheduled video visit appointments. So at the point that THA, the Telehealth Associates, had recruited 1,000 LISH CCM patients and wanting to get ahead of the telehealth curve and betting on eventual reimbursement to RPM and telehealth visits, LISH was willing to invest in 2 pilots with CCM enrollees. The first was to provide RPM and video visits for a cohort of patients with hypertension. And the second pilot was to exchange on-site behavioral telehealth visits for telemental health visits. So we developed workflows and clinical protocols that incorporated RPM, CCM, and telehealth visits. We educated individuals and caregivers on the value of participating in our pilots. One of the tips that we learned here, for those of you who are running a CCM program or thinking about it, is that we recruited people into the CCM program with the promise of telehealth. We found that when we talked about telehealth programs that individuals and their caregivers were more interested in participating in CCM. So when it came time for us to introduce telehealth, they were enthusiastic already. We vetted equipment and tested many RPM vendors based on ease of use and clinical dashboards and alert management capability. We trained providers on how to do alert management and video visits, and we looked at the impact of these pilots on scalability, efficiencies, and clinical outcomes. And let me say, the big aha for us was how many caregivers and patients did not have digital competency or sufficient connectivity. We found ourselves having to go into each residence and teach individuals and caregivers how to use the internet, how to check broadband and cell signals. This obviously was not scalable. So we developed connectivity assessments, RPM readiness assessments that the CCM coordinators used to screen all enrollees to determine who would be most successful with RPM and video visits. Based on the results from those assessments, we realized that we needed different learning approaches to address the digital competency issue. So one of those areas was to create super users who could train staff in a congregate setting or in a practice, use booklet tutorials for those not comfortable with technology, create video online help guides, call center troubleshooting numbers, and we needed Wi-Fi boosters to address the broadband issues. This approach of pairing CCM with RPM and telehealth visits to touch the patient multiple times in a month resulted in massive learnings that shortened the learning curve when COVID hit and also helped with the continuity of patient care and clinic revenue. Next slide, Dr. Powell.
So unfortunately, even still to this day, RPM is still not a reimbursable service in the FQHC. It's still listed as being part of the comprehensive approach to a patient. But what we learned is that when you look at how do you create the right time, the right place, the right technology, you really have to be agnostic in your approach. What we realize is just RPM, and specifically, it's kind of like dating. You got to find the one that works for you. There's no real true magic, I think, technology out there in terms of patients understanding, patient ability, integration into your system. Even alert management becomes a bit of a challenge. In fact, our program was really not a robust alert management program. It was really a bit more data collecting. Just to say, okay, we're going to look at the information once a day. We didn't have after hours and alert type of stuff. We're getting to that. But deploying the technology, utilizing the technology, again, even though it wasn't reimbursable, we knew it was going to create an opportunity for us to do that. So you can't really have a one-size-fit-all really with anything. In fact, we'll talk about in a little bit is that we've decided that it's not about, whether we use Zoom or we use DoxyMe or what system is that we have the system in place for the organization so that as we change down the road because needs change or requirements change that we're prepared for that. And I think that's really how you look to get yourself ready. Next slide. So we kind of came up with this concept of, how do we kind of create an envelope of care? And what we mean about that is that, we joke that most health centers have worse hours than banks, grocery stores, et cetera, et cetera. So we are really not on the cutting edge of creating opportunity for patients to, one, reach out to us or for us to reach out to them and find out what the needs are. So we wanted to create an opportunity where we can look at all the services that we provide, whether the provider's on-site, the provider's off-site, there's RPM, there's chronic care management involved, that we're all able to reach out to see what the needs are. So what this does, it kind of creates what's called a quality of touch. And so the concept is like, how do we look at what we're doing, how we're reaching out to a patient, and what kind of value is being created by that. So, kind of modification of a real life example would be that we have some artificial intelligence that we're working on with the company now, is they'll send messages to the patient before their video visit, confirming that they have the Zoom ID and they have the technology and they're ready for the visit. So a quality touch. A patient sees me for the visit. I order, let's say, the Cologuard for colon cancer screening. the CCM team, a couple of days later, a week later, would follow up to make sure they had the completion of the results, and we get an abnormal result. And the provider gets back on it and explains the details of that. Now, we can look at the difference in what that quality is, but all those pieces are important, because if the CCM coordinator didn't reach out to the team, to the patient and say, please make sure you get this done and create the buy-in and the education, maybe that wouldn't have occurred. If the artificial intelligence didn't make sure the patient was on the visit and ready for the visit, these outcomes wouldn't be there. So we're actually even looking to how do we kind of explore what the quality touch is, almost really in a way that can be mathematical, in the sense that we're looking at time, effort, over cost, to create some sort of value of where we are and where we're deriving care. So that's what we're looking at. So we can do value based on texts, calls, patient portal, video visits. All these things become the part of the quality of touch that we're looking at. Next slide, please. So then COVID came in and really changed the game. We felt blessed that we were part of a program already, so we had our feet wet. We were by no means experts, but really came down into, our walk turned into a very quick race. So we kind of say that we were running a race without a clear end in sight, without knowing where the finish line was, and we had a bucket of water that was losing water. We didn't know if we were going to make it there in time. In fact, we're still losing money as an organization, but losing less and preparing. But at this prep work we did before and the prep work we did now within the last couple of months is really helping us kind of survive. And really survival comes down to keeping your patients, keeping yourself sane, getting the providers on board, and really working towards understanding what the opportunities are. Next slide, please. So many of us became experts in change management. And really what we looked at is change management in what I call a triangle of care, where the patient is at the top part of the triangle, the providers are at one side, and the organization is at the other. And change management can be important for all three of those pieces of the triangle, because if something doesn't work, then obviously there's going to be problems in terms of the rollout and the effectiveness of the program. So we really defined ourselves and defined everybody else into the three different stages of what is considered a change management. So for example, the oh crap bucket is for people who think telehealth is too much. They don't know if they can handle it. They don't know if they have the IT or the know-how, the capabilities to do that. So those are the people that kind of fall into the oh crap bucket. The OMG bucket for us is really about, I need to know telehealth. I understand that I've done some telephone visits. I'm doing some video visits. I know I have to take this to the next place, but I don't really know where to go. I'm kind of searching for guidance. And the oh yeah bucket is those who are already doing telehealth or who embraced it quickly and made it part of their regular routine, and they want to stay ahead of the curve and make it sustainable. And I think that's important to, one, look at those three buckets in that triangle of care. So when you direct your efforts, you're looking to where effort and energy has to go. Next slide, please. So quick.
Yeah, go ahead, Dr. Powell.
No, I was going to say, so just an audience poll for this, just curious about your organization and what kind of bucket you felt you fall into in terms of your organization, just to get an idea of how people are at this present time. So the 1, oh crap, 2, OMG, and 3, oh yeah. Great. That's music to our ears. That makes the next slides certainly much better. I'm going to go into the next slide, please. So we had to do is, from an organizational standpoint, an employee standpoint, and a patient standpoint, change their mindset from fear to survival to growth. That originally a lot of the providers really based out of fear said, okay, I'll learn telemedicine, I'll do virtual care, I will get ready because I'm going to be out of job, my patients are going to be in trouble, and how do we get this on board? And we had to be honest about our uncertainty, that we had to really be transparent about what our economic situation was, how we're going to be losing money. For those in the FQHC world, you may know that you didn't know about getting reimbursement for weeks upon weeks upon weeks, specifically with us, with the dual eligible. So Medicare in the telemedicine world through an FQHC wasn't fully understood, and for quite some time. So But we said, you know what, don't lose the skills that you're good at. Don't be afraid of adding the new technology and looking at the opportunities. And so how do we discuss what's going to happen, discuss what's going to take place? And this is one of the slides we actually did. We had weekly meetings with all our staff as a total group, but also individually through departments. And we tried to explain to them that, listen, you know, we want to make a change, and we have some desired state of where we want to go, you know, full video visits, getting to every patient. You know, things are going to get worse before it's going to get better. And again, and over time, there's going to be different dips like this, whether we roll out new things. But don't be frustrated with the failure. You know, keep your eyes open and understand, you know, where you are in the world you're living in and how you can adapt to that. And when we started having these conversations about, you know, what works well and what doesn't work well, the kind of thing that struck us quickly is what worked well was the engagement and the interaction with everybody. You know, I had this, many of my bad jokes is that, you know, when I first do telemedicine, I said, when I'm in the office, I have to type so much. I just want to put a big bus smear up over my head so I can just look up and say, show me your rash. I don't have to turn around because I don't have time to dictate, write my note, and see a patient. You know, virtual care in this Zoom platform world, I see them, I engage with them, I become part of them. So the staff really bought into the idea of, wow, I'm really creating relationships. And then we started talking about what doesn't work well. And I said, has anyone been on a Zoom coaster? And everyone said, what's a Zoom coaster? I said, you know, when you get logged onto the screen and you put your hands up in the air and the patient or the staff brings you down the stairs and up and around their house until you get to where you have to be. And you just kind of take your arms and you go like this as you do in the session. So, you know, everyone laughs. So, you know, because how do we kind of create opportunity for people to understand, you know, what we're going through as well as what they're going through. Next slide, please. So we'll wait for the next slide. So every week in our sessions, we just said, you know what, we're going to come out and be completely transparent about how we are as an organization. And we tried to use prior to the pandemic as our guide, because that's what, oh, I'm sorry, you have to go back one slide. We have to go back to, you know, what we did behind pandemics. People only remember what they did prior to the pandemic. I'm sorry, if you can go back one slide, please. So we looked at our weekly numbers and tried to match out what people were seeing on a weekly basis. You know, prior to the pandemic, we would average about 1,300 visits a week. Budgetarily, we've actually budgeted about 1,600 for May going back to 2019. So we're not anywhere close there, but we wanted to show where the progression was of just what each service is doing, and not only how they're doing it, but how we're breaking down the on-site, the virtual, and the telephonic care. That, you know, what we're looking to create is an opportunity to say, okay, well, not only are we creating opportunity for visits, but how we're delivering those visits. How many are we doing on-site? How many are we doing virtually? And how many doing telephonically? Now, for us in FQHC, you know, telephonic visits are not as reimbursed at the same level as an FQHC virtual visit or on-site visit. So for us, we were down now to about 20% of our visits by telephone, and mostly in the behavioral health world. We'll talk about in a little bit that we actually also won the FCC grant with another FQHC, so we're in New York City. So we're looking to create a whole Montauk to Manhattan type of approach and really direct our care to those who can't get access to services, and specifically those who are getting telephonic services. So for us, what we're looking to say is it's just not about getting the technology that was beginning the buy-in and the understanding. So in theory, a couple of visits, if you buy a tablet to get and deploy to somebody, will create an opportunity then for services. But we went a little bit deeper in this as well. Prior to the pandemic, we kind of came up with this philosophy of just talking about wellness in general. You know, how do we look at medical, behavioral, social, and financial wellness? And again, not just for the patients, but for the organization and for the employees. So that same type of triangle of care was our wellness model as well. So we spent time talking about meditation. We took time talking about the 401ks. Do you take money out? We spent time talking about how do we help each other out. So, you know, extremely valuable opportunity for us to kind of get together and work. And in fact, what we did was actually made a decision administratively that we gave a lot of our individuals a day off in May. It was not paid. We couldn't create a bonuses or anything else, you know, because we were still losing money. But we gave everyone a May mental health day. So it was a day that they were able to take, wouldn't go against their benefits, to give them a break from the reality. So as you'll see, one of the weeks, at the end of May, there was a drop in visits because it was even providers. Providers needed a day off. New York, as you know, is like many areas, was hit very hard in terms of what the services were available and what people could handle. If you can go to the next slide, please. So I've been lucky enough to be part of a whole bunch of different conferences and talk to different people about their programs and what they do. And one of the things that kind of strikes me is that people aren't mindful of the whole process and all of the variables related to virtual care. And I'll go on these talks and I'll hear people say that how great they did. They got these urgent care visits done with the video visit and they avoided an ER stay and ER costs. And those are wonderful, wonderful things. But one of the things that always struck me when I was a medical student was that when I was learning about abdominal pain, a teacher pulled me aside. It says, you can break down all abdominal pain into 3 pathophysiologic causes: inflammation, distension, and ischemia. And 99% of the time, you're never going to see ischemia or low blood flow to the bowels. But if you think about it, then you never forget it. And so what we're trying to do is create the opportunity for people to see what are your capabilities in the virtual care world. So let's look at not just urgent care, let's look at episodic care, let's look at chronic care, let's look at preventative care. How can you roll out an immunization model? How do you roll out an RPM chronic care model? How do you roll out an episodic model, maybe through a COVID case where pulse oximeter is needed? But how do you look at all opportunities of care and not just the urgent care piece of it? So if you're always thinking about, and this goes for different specialties as well, it's not just medical, there's also behavioral health and subspecialties as well. And then when you look at the modalities, I think one of the things to think about is, well, there's a lot more than just video, right? We reach patients by text, by phone, by email, portal. There's virtual reality opportunities, artificial intelligence, chronic care management we talked about, RPM, video, deployable equipment with Bluetooth technology, et cetera. And then even virtual care within your brick and mortar structure from site to site, store and forward capabilities. So again, thinking about all those opportunities makes a big difference. We've been very fortunate to partner with an artificial intelligence company to talk about getting that piece to our patients and reaching out and minimizing some of the mundane work that some of the providers and staff have to do. So we're looking to how do we explore all those things. So I think that when you look at sustainability, now you may not want to get into RPM or CCM, but as long as you think about it and think about how it can interact with what you're doing, and that's really where the true value is. So again, don't think about just the 1 or 2 pieces of what you're doing in terms of care, but think about all the opportunities that there are for you. Next slide, please. So, and I wish I can give credit to who created this slide because it's been modified, morphed quite a few times. But the thing that we also wanted everyone to understand, especially our staff and the people that we serve, is how do we look at the waves of not just this pandemic, but of where things are going and how things are going to be directed at. That yes, we went through the immediate crisis and we went through things are, and now we're dealing with the second wave of restrictions and things are starting to open up, and now we're dealing with the third wave. And especially our mental health team and even our primary care team not to ignore that fourth wave of mental anguish and stressors and things going on. If we go back to thinking about the slide about the visits, if we're at 1,100 visits a week now, we're anticipating that we're probably going to have about 500 visits on site by July. That would be a conservative number. So again, 1/3 of what our normal visits are. I have no crystal ball, but I would be very surprised if we have more than 1,000 visits on site when we come back, say after Labor Day. So being mindful of where the new normal is and the variations of normal, and also how the waves of this is going to roll out, is really important for us to kind of consider. Next slide.
So we work with a lot of different practices, and we've learned some things that to share with you about this new world that we're living in, this new world of incorporating virtual care into your on-site clinic. And it really, as Judd was talking about this morning in the keynote speech, it means offering the same care delivery experience that individuals, the patients expect from you, whether it's virtual or on-site. You want to minimize interruption of workflows, your scheduling system, portals that your patients and providers are used to. If patients love your responsiveness in scheduling appointments, use the same scheduling workflow for virtual care. If they love their doctor, make it easy for the doctor to do virtual visits to keep those patients in your ecosystem. We have seen clinics try to operate virtual care services with different triage staff, different call centers, different scheduling workflows, different software platforms, which create more resources, more expense, more confusion for both patients and providers. And disruptions in service can erode your brand of care that you have worked so hard to create and to bring loyal patients to you. Understanding providers' preferences is hugely important, and this is what Dr. Pell was talking about. Know what buckets your providers fall into. Those that are in the "oh yeah" bucket are likely to have motivation and competency to become virtualists, like hospitalists. We're talking about virtualists now. They can be the role models for your future. They can help define what a successful telehealth visit is and a successful telemental health visit is. And Dr. Powell, I know that you talked about creating successful telehealth. What does a successful telehealth visit look like for different conditions? Like if you're treating rashes, what does it mean? How is it different than being in an on-site visit? Those providers that are OMGs may have the motivation, but not the skills. So teaching them to be virtual care doctors is worth the investment because they're motivated. And those in the oh crap bucket, well, they may just only do on-site visits. Don't force them to do other things. This is what they're comfortable with. You know, and today's patients really want flexibility and choices, and you're hearing that, and I'm sure you're experiencing that too. And even though your office is closed, the practice isn't. You'll have to let them know it's safe to be there. Let them know they have choices. For example, they can be seen today at home. They can be seen tomorrow face-to-face. They want to be able to access their own medical information 24/7 via the clinic's online patient portal, or upload a question, a picture, or a video file to their care team for a later review or a later response. They want to choose, do I use text, email, web, virtual assistants to schedule visits and labs? If you're a hybrid practice, you can care for patients who are not digitally competent and never will be. So I think the point of this is that as we talk about sustainability, we're talking about ways to create efficiencies so that you can keep your costs low. At the same time, you're incorporating virtual visits into the way that you do business today. Next slide. So here are some final thoughts that hopefully will bring all of these ideas together. The first is, no matter where you are in adoption of telehealth, leadership is critical. And anyone can be a leader to help move towards sustainability. It doesn't have to be positional. It doesn't have to be Dr. Powell, who's the CEO of Lish. It can be anybody in the organization exhibiting leadership traits. And I like to think about leadership in three areas, 3 B's. I call it believing, behaving, and belonging. And as we talk about believing in it, demonstrating all your communication, verbal, body, everything, written, messaging, is all indicative of being supportive of the objective of moving now into this new world that we have. Behaving, all your activities demonstrate unwavering support for moving in this direction. And it means stopping behaviors that are not helpful or supportive of the objective. And belonging, motivating others with your mission, showing people they belong to a team with a mission. You know, we talk about, it's not the tech, it's the touch. 10% of a telehealth solution is technology. And this is another thing that was brought up in the keynote. 90% is showing people, caring for patients with quality touches, with multiple quality touches, in a process that is comforting, accessible, and easy. And the third area is the answer to every question. It's a hybrid. This is your opportunity to be competitive, to bring new patients into your practice, expand your reach, and increase access to your care, and giving the patient the choice of what they want. And we talked a little bit about adequate connectivity and digital competency. Really, I think this was the biggest concern that we have, is it's essential for both patients and for providers to be comfortable with with this technology, so that we can leverage all the telehealth aspects of a hybrid practice. Dr. Powell, maybe you want to add to those 4 and talk about 5 and 6.
Yeah, so I'm going to actually jump down to number 6. The EHR piece, I think, is something that we have to try to remember. I still have the scars of going from paper to EHR back in the day. I mean, I started my private practice with a folder, didn't even have dividers, we just stuck notes in it, and then we went into an EHR system. And what happened was the EHR is really created from a provider standpoint, just more work, because it was all about more clicks, more data, more entry, more information. And so all we did was add extra time and effort for the same amount of dollars that was being received. So a lot of providers had a real hard time. In fact, some of my senior providers back in the day actually even retired and didn't want to go into the EHR route. So having that concept is important, because I think the EHR system is more of a marriage. You're really committed to that technology, committed to that system, whether it's Epic, eClinicalWorks, whatever, and they all have their pluses and they have all their minuses. But once you invest that much time and effort into them, you're really kind of stuck with them. It's a big lift to switch to a different EHR. And if you're agnostic in your approach to the virtual care platform, and you think about, well, this may be my RPM technology, or this is my CCM vendor, or this is my AI, coordinator, you don't always have to be stuck with it if you create the workflows and the concepts of what you're trying to deliver, because this way you could take the technology out, put in the new technology. Obviously there's changes and has to be done. But so what we decided, and we've been very happy with Zoom as our platform for virtual care, but we went month to month because we didn't know what was going to happen. We were going to be committed to. We didn't want to do a long-term contract. So I'm paying, $700 a month for my Zoom licenses to get HIPAA compliant software. So it's coming out to about 25 cents, a visit, which is pretty cost effective for us. But we thought if technology changes or things happen or something, we want to be ready and be able to change. So always be mindful of for those that have been in the field long enough to realize how those scars from the EHR still linger a little bit in terms of the work that we do. And that when right now what we decided to do is really pay attention to actually what's happening in the visit. So we've created an after hours and weekend type of opportunity so patients can reach out to us and get a virtual visit on the weekends and later in the day, which is working out very well for us. But as I've done some of these visits myself, I realized that now I've become the scheduler on the Saturday when I do the sessions. I become the nurse, an MA entering the data, and I become the provider. So this 15-minute rash session could take me 30, 45 minutes. And if that's happening to me on the weekends, well, what's happening to my staff during the work week of the 8 to 6 that are open. One of the things that we were very fortunate enough to do is when we went to chronic care management, we had the opportunity to not lay off any of our MAs, LPNs, and RNs because we put a huge amount of effort into our chronic care management program. So the staff was redeployed to the CCM team, which has allowed us to kind of have that be part of the system. But now as we bring back on-site visits, and so we have our different workflows that we have on-site, we have virtual care, we have CCM, and we want them to be seamless so that the providers don't feel like they're being neglected when there's an on-site visit. The nurses don't feel like they're overwhelmed because they have 3 or 4 things going on at once. And we're still not doing it right. So come back to the number 5 is, failure doesn't mean it's the end of the process. It just allows you to rethink what the possibilities are. And we'll tell people right off the bat, listen, we're doing 7 things right and 3 things wrong. And the next week, we're going to add 1, take away 1, but you have to be nimble. You have to understand what this process is about, encourage the efforts of where things have gone, because this is the opportunity that you have to be mindful of what's taking place. So as we talked about going from, to survival to growth mode, I'm also being conscious about not having my providers and my staff burn out because they just ran out of gas fumes. How do we kind of look at where we're going to be in terms of the long-term benefit? Because even as the summer rolls on and there's still all these hybrid models of care, we don't want to keep adding work. We want to kind of minimize the work. And that's why we've really leveraged our relationship with First Outcomes and the artificial intelligence to have some of that other stuff taken off our plate. So we're not making the phone calls. We're not sending the texts. We're not verifying that they're available to come to the visit. So that's really making a big thing. In terms of sustainability, Again, I go back to my buckets of the organization, the patients, and the providers. And so sustainability for me is looking at, well, now how do I look at the rent I pay, the buildings I use, the services I'm offering? Is this going to make the new normal? Because we don't know what the future has and what the government's going to tell us what it can and will not allow, but I will be willing to bet that fee-for-service is going to go away, that there's going to be some value-based oversight of everything that we do. And so that if you're looking at RPM now, even though you may not be getting reimbursed for it, and you're dabbling with different other modalities that may not be reimbursed for it, you are looking and creating a pathway to value. And value is driven by the amount of quality touches you can create and generate. So if we can get more of those, when we are all set for the value-based payments, global takeover of care, which I think is going to happen, you've already done your detective work, you've already done your research, you've created some little pilots to see what works, and you're ready for those next steps. And that makes a big difference. In terms of sustainability for patients, it's also meeting their needs. And so it's interesting. So I don't want to send a text message or an email or a call the same way to every single patient. Some patients respond and they like the alerts. Some patients need more. Some patients need less. Some need to be escalated, not just to an AI bot to ask them if they confirm, but they may need some of that warmer touch from a voice as well. So how do you create a pathway of thinking about there are unique patients, there's unique opportunities. You can generalize a lot of your workflow, but you still have to look at what the opportunities are to kind of get to the specific patients that you have. And some may be patient, pools, those with substance use disorder, those with chronic conditions, those with developmental disabilities. So how do you look at your patient population and really create opportunities that's targeted, for them? And that's where I think where the connection piece is. And that's where you create the buy-in. And so if you can look to take the opportunity to have your sign language interpreter jump into your Zoom visits, and you can have your the bilingual interpreters jump into your visits to kind of create buy-in and comfort, then I think really you're making your opportunity for sustainability much, much larger. The next slide. So that kind of comes to the end of our talk. We love what we do. We love being part of this. We think this is we've been waiting for this. Terry and I and my team have been joking around this, waiting for the reimbursement. And you got to be careful sometimes what you wish for, because, who knew it was going to hit us in the face as quickly and as powerfully that, from that standpoint. Again, I'm not trying to minimize the pandemic. I'm just talking about the technology and the availability of access to care. But we'll certainly open up to questions and anything else we could do to answer. And, we're a resource. I was I am of the feeling I'm in the nonprofit world. We do this because we love it. So if we could ever answer a question, guide you in a direction, we're more than happy to do so. So feel free to reach out to us even after this.
Terrific. We have about 15 minutes for questions, and coming from I want to make a personal comment, coming from a grant-making organization like HRSA, I was very interested in hearing that presentation, and I thought that was just excellent. So thank you so much for that already. So everyone, please remember that we're using the Event Mobi app for questions. So please go ahead and post your questions there if you haven't already. Also continue to upvote them as you like, the ones that are there. Alternatively, if you'd like to ask a question by voice, please go ahead and raise your hand and we'll unmute you as we can. I'll begin by reading the questions that are at the top of the list, which Reed is showing us here, so we're all looking at the same thing. And so the first being, were any patients excluded from receiving telehealth because of lack of readiness, either digital literacy or connectivity?
Yeah, so quite a few of our patients, and in fact, that's why we feel blessed to have had the FCC grant awarded to us, because that's really where our efforts are going to go towards. In fact, we kept Excel spreadsheets about what was the reason. Was it technology? Was it literacy? Was it connectivity? All the above, so that part of the grant dollars we put in for hotspots, for boosters. We're going to put videos on the tablets to explain the technology. We're going to use the artificial intelligence to help them guide themselves to getting the visit set up. So that's really where a lot of our efforts are going towards. And we also found out that we're not meeting the needs of the community who don't even know about us. So we made big campaigns to everyone on a roster that if you want to visit, come see us. We were offering telemedicine visits for $15 if you had no insurance. And we said we would bill you 60, 90 days from now. And unfortunately, we really hardly get any of those requests, which is a shame, but because we wanted people to feel like they had a place to go. As other speakers have said, there is a lot of access, but we don't know how to really maximize it. And that was part of what we had done with the FCC grant, which we think will help us next phases.
I'll just mention about remote patient monitoring. We did remote patient monitoring assessments for every individual that was a CCM enrollee. And we evaluated not just the technology, but their ability to be compliant with the readings, and also their ability physically to, were they physically competent, were they functionally competent to be able to take the readings without shaking, or not to be upset if a thermometer touched their forehead and something like that. And for those instances where we weren't able to offer RPM because there were those limitations, there is an approach where the caregiver can call in, help the individual take their readings and call the readings in to the care team, to the CCM coordinators, or to the care team at LISH, and have them be monitored that way without the use of technology. I think it goes back to what Dr. Powell was saying, is that one size doesn't fit all. You have to have multiple approaches given what the needs of the patient are.
Thank you so much. Let's move on to the next question. Can you discuss accessibility for sensory and cognitive disabilities? Especially curious about accessibility for participants with hearing loss.
So prior to the pandemic, we had a relationship with an organization who is our sign language interpreters, and they would actually come on site for the visits with us. What we did was, as this COVID unfolded, is we created the opportunity for them to be in the Zoom session for us. So we invite them in, they get to participate in our code, the provider invites the interpreter, as well as the patient. So it's been helpful to have the three people in terms of doing sign language in the translation services. So there are definitely services out there. Some are more expensive than others. So if you have any questions specifically, I'm happy to give you some links to some companies we talked to. Again, it's like an RPM type of thing. We learned a lot by making mistakes and engaging conversations, whether it was sign language or Spanish or some of the other languages we tried to implement into our services. But it's definitely feasible, but there is definitely costs associated with it.
Terry, anything to add to that?
No, no,
Okay.
not right now.
Okay. So next question. I bet more than two of you had to step away for a moment, but two of you have the same question. Discussing billing, FQHC billing of CCM without a copay. How did you manage to eliminate the Medicare coinsurance?
So I can speak to New York. So New York, we're allowed to waive the copay because it's deemed that we don't want to discriminate based on someone's ability to pay for a service that's available. So I can speak to New York. We've vetted this out, and so we're allowed to eliminate the Medicaid because most of our patients are Medicaid as our secondary. So we're able to eliminate that. So I don't know if it's a state-specific issue, but I know in New York we were certainly allowed to. So you may just want to look at a state level. I don't know about the national piece, Tara.
Yeah, I think right now during COVID, the copays are waived, and we don't know if that's going to be resumed after the pandemic. But the average amount of reimbursement from Medicare is about $55 to an FQHC without the copay. So that provided some financial assistance, and then when you add the addition of RPM and the addition of telehealth visit reimbursements, that can have really has a more significant impact on your revenue stream.
And that was a nice lead into a relationship to the next question. How are you handling COVID in group homes?
So where we are in Long Island, we were hit very hard with COVID. In fact, a lot of our patients in our group homes that have developmental disabilities, I think the statewide numbers are in the thousands. I think it was like 3,500 patients in total have been positive based on testing. The group home is an interesting environment because you're not just dealing with the patient who lives in the group home, but the other individuals who live in the group home and the staff who work with them. Most of the agencies really created their own, with the guidance of in New York State through OPWD, of the isolation and the quarantining, limiting visitation, limiting services. So they really shut themselves off completely from any visits for us. So we made sure we definitely got the tablets out to them, had constant contact with the nursing staff. In fact, part of the FCC grant is to create these COVID-like kits so that if someone is suspected of having COVID, we would deploy the tablet with the pulse ox, and there's even a sleep ring we've looked into the checks oxygen levels over a 24-hour period with stethoscopes so that we can kind of keep an eye on the house. So we'd watch them for the 14-day period and then give it to the other individuals in the home. So we're trying to be as very aggressive about the group homes as we can. Now that things have lightened up as we're getting into quote unquote the near normalcy of what's going on, many of the group homes still don't want to come outside and come into the office, which we understand. So one of the things we're actually looking at now is maybe opening dental, for example, on a Saturday, and only that house comes in with that dentist. And this way they feel like they're not mingling with the staff and the patients who may be in the waiting rooms. The on-site stuff, we've done everything from wait outside. You can actually push a button on our telephone answering service so that when you call, you can say you're here, and then they'll come out and get you when you're ready for appointment. So you have to be flexible, know what the needs are. It's hard to have one approach to the group homes because it's going to be based on one, the disability, two, the number of people in the home, and two, the agency's philosophy on oversight. So it's a little bit tricky in terms of having a consistent workflow, but you have to kind of create almost like we talked about, hybrid is the key word, hybrid models of care delivery for the group homes as well.
I'll just add to that LISH has created a testing protocol for group homes and is exploring how to bring the testing into the home and have everybody in the group home be tested. And then based on those results, has a protocol for how do we treat the individual who tests positive and how do we treat the rest of the people in the home using technology, using remote patient monitoring and video visits, depending on what the condition in the group home is. I think Dr. Powell, you're working with a lab that is willing to do some testing, come into the home, do the testing and provide the results so that there can be an approach for the entire house in intervening.
Terry, who did you say created that protocol?
Lish, and Telehealth Associates is working with Lish to create that protocol, as well as the lab that is willing to be a mobile lab going into the home.
In this way, yeah. So we'll do a video visit. We can, in theory, screen a whole house for COVID exposure and talk about antibody testing and order that type of stuff. And that workflow may translate to other things, flu shots down the road and your wellness visits down the road, treating the house like a family in terms of that unit. So what kind of services can we get to them? And even, when it comes to technology, well, some staff agencies can't handle the technology. So we're saying, well, what else can we do? Do I create an Uber Health-like model? Do I hire some staff member on my own to deploy a tablet, give it to them overnight, pick it up the next day? So let's not create any limitations in ability to create care. So we're looking to deploy about 250 tablets by August. That's our goal through the FCC grant. So we can get that out to individuals, into group homes and agencies. So, and then some that may be mobile and picked up, dropped off, deployed, based on the needs and the services out there.
We have 3 minutes left, which might be just enough time to answer this very last question. So noted not just about telehealth, but how do you incentivize staff to do the work to have custom communication with patients?
So incentivize is an interesting term. So there's no, at this point in time, any real true financial incentive to do so. We're trying to look at some of the outcomes and the aha moments and the buy-in of what took place. And that's where it comes with the dialogue of our experience. So when we talk about, well, why were you successful? How do you get the patient to talk about what they would do? Because for us, it's not that we're changing that this is how you treat a diabetic, this is how you treat a hypertensive. It's how do you become a little bit, sometimes used car salesman in terms of your approach. How do you reach out to them in the right way that's not too overbearing, but sometimes encouraging and reassuring? So that's the kind of interesting network that we're just starting to look at. Kind of our eyes are open. We kind of say, pretend you're outside the exam room and look back and say, how did that experience go? What could I have done better? What would someone else have done? And so we just starting to create these conversations and just look at the ways that we can provide better care.
This is a great question because it comes back to the idea of staff performance is a combination of motivation and skills. And, why are staff resistant to having custom communication with their patients? Why is it that they want the patients to adhere to their workflows and not the other way around? It's an excellent question, and you have to, individually, each staff person has a combination of how much they're motivated to change and how much skill do they need to make that change. So it's almost like you have to treat each individual differently based on what they're coming into this new normal with. Sometimes people who, and I'll just say this, sometimes people who are not motivated are the hardest to teach the skills to. And sometimes it's just not worth the investment.
That's perfect timing, and that's a great way to end this session. James and Terry, you're a terrific team, and that was a terrific presentation. Thank you so much. And participants, thank you for participating. Please remember that feedback about this session is being collected through the Event Mobi app, so please don't forget to go there where this slide is pointing you to. And hope everyone has a great afternoon.
Thank you, everybody.
Bye, everybody.